go up, and so logically that should help. All right, on to the presentation. Tonight I'm going to talk about concussions first. I'll show you some normal examples of scans. Then I'll show you some abnormal example of scans. And then we're going to see some live video of a patient of mine who sustained a severe brain injury and was treated aggressively for about 5 or 6 weeks, made some significant neurological recovery, and you could see that on the video. So, anybody have an idea what the answer is to the question on the slide? Everybody could read it. What does a fireman and COPD patients have in common? Anyone have a clue? Oxygen. And that's why oxygen is considered to be king, because the body depends upon oxygen for everything. As soon as you have any reduction of blood flow, you have a reduction of oxygen, and bad things start to happen. So the diameter of the blood vessel is very important because that determines the flow. The bigger the diameter, the bigger the flow, and the smaller the diameter, the smaller the flow. And that's very important clinically because there's a number of conditions, including concussion, where there's a narrowing, probably due to a spasm of the arteries, that decreases the size and reduces the flow. And that's a problem. So what is the test that is used to measure the blood flow in the brain? It's called the SPECT scan. Of all the different kind of scans, this is the only scan that can show the blood flow in the brain, and specifically it shows what's called the microcirculation. The SPECT technology is not new. It's similar to what is done when you go to a stress test for the heart. It's called the thallium stress test, and they scan your heart with thallium, and they get slices, which I'm going to show you slices of the brain. And so we get different views, and I'll show you them in a minute. And so it's very important because this is a functional test of the circulation as opposed to MRI or even MRA or even PET scan, which MRI shows you only the structure. If a person dies and they do an MRI of the brain, it still looks normal even though they're dead. PET scan is a little bit better because it shows you the metabolism, typically of glucose, but glucose metabolism is not the problem in concussion. In concussion, the problem is blood flow. So that's why you have to have a SPECT. So what is a SPECT scan? Well, first of all, it's a nuclear test, which means that they have to inject you with a radioactive isotope. Now, that sounds scary, but it's not. It's a very, very tiny amount of radiation, and most people don't get a whole bunch of them, like a chest x-ray or a CAT scan, so you're not exposed to a lot. So the information that we get, the advantage of the information that we get greatly exceeds the little tiny danger there is from the radioactivity. Person is injected intravenously. Isotope goes to the brain. We use one that's specific for the brain. A camera is set up outside the person's head. The radioactivity actually comes out of the head, goes into the camera, and the camera sends it to a computer, and the computer has a special program that can convert the data into pictures, which is what we're going to see. Some of this I already said, so I won't repeat it for the sake of time. There are different qualities to the camera that's used. The first set of normal slides I'm going to show you with an old machine, with the first generation, because I have normal ones. The abnormal ones I'm going to show you more modern, more sophisticated, more sensitive, with much greater capability. And everyone that has gone for that scan has been abnormal, so we don't have any normals of that. So how do we present the data? Well, there's different ways, and there's certain unique possibilities when it comes to SPECT scan. So these slices here, which you see for an MRI and a PET scan, are the same as always. Those called 2D. And the big difference between the SPECT and the others is that we have the ability to do 3D. And the 3D shows us the surface of the brain, which bears the brunt of the injury. When somebody has a concussion and the head and the neck is going back and forth and the brain is rocking and rolling inside, it's actually getting pushed up against the skull. And the brain is a very delicate substance, and it doesn't like getting hit up against bone. So the 3D turns out to be very important to see the surface of the brain where the injury is the worst. And so now we'll see the examples of what a normal scan looks like. Before we see the scans, I got to show you the flow scale so you know how to interpret the scans a little bit. So there's two kind of flow scales. There's a black and white flow scale, just like there's black and white pictures, and there's a color flow scale. The principle is that the dark colors are on the bottom and the light colors are on the top. So the rule of thumb is that if we look at the color ones, which is usually easier to see things, the hotter the color, the higher the flow. We expect the brain to have a high flow state because it's a very highly active metabolic structure. Of all the blood pumping out of the heart, the brain takes about 25%. But the brain only weighs about 2.2 pounds. So it's a little tiny organ compared to the weight of the body, but it's getting a quarter of all the blood flow. So that shows you something about the metabolic need. So here we go with the examples of the normal. And I'll call your attention to the flow scale here, which is what I just taught you. And you see that the hot colors are here to the top, and the dark colors to the bottom. And these are slices from the bottom of the brain here going up to the top. And if you just look at it in a global way, you see everything looks red. There's a little bit of white there, deeper in the brain. And everything looks kind of symmetric and convex and kind of thick, and kind of keep that image in your head. So those are slices from the bottom. And now we'll see these are slices from the front to the back. So here's the front where the brain is smaller, and as you start going back, it gets bigger and bigger. And then when you get to the middle of the brain, you have these other big structures here. You see it's white. It's at the top of the scale, so that's great. On the abnormal ones, you're going to see these better. These things hanging down here, once you get past the first part, those are the temporal lobes. And those are the second part of the brain that bears the brunt. Because the front of the brain is not fixed, the back of the brain is partially fixed, so the part that's mobile moves more, gets more acceleration, deceleration, more force, and more injury. And so there's a gradient, which I'll show you when we get to the abnormal ones. Notice this frontal lobe here. This is very important. This is like a ring. Think of that as a ring. The top, the bottom, the right, the left. It's thick and it's very regular. So try to remember that. And these are slices from left to right. These happen to go from, These happen to go from left to right, and so this is the front, and this is the back, that's the top, and that's the bottom. And again, you see like a ribbon. They call it the cortical ribbon, and it goes all the way around, and it goes under, and you can see it's nice and thick and regular, and it's solid red, and some places have a minimal interruption, which is not even significant. And then you see the white again, and you see the white also at the bottom of the brain. You can actually see that better in other slices, but that's not important. So here's the 3D. So the 3D, like I told you, shows you just the surface of the brain, and these are 16 views, and the brain rotates about 22.5 degrees each time, and that's so you can see all the surfaces of the brain. So this is the view head-on. It tells you that, anterior. So this is right and this is left. And here's the frontal lobes here, looking pretty white and pretty smooth and pretty regular. And down here, like earlobes, these are the temporal lobes. And you can see that they're below the frontal lobe. And you can see they're very round and they're very oval. As it turns to the right, this is the right view, you can see everything is very smooth and regular. And here it rotates around. Here's the back, and you see it's all white and smooth and regular. And here's the left side, and it looks really good. Where do you see the others? So everybody talks about concussion in football, and everybody knows that football is a violent game. I love it. I played it. And this is just a little sarcastic humor about the consequences of concussion. So now we look at what happens to the brain when you have multiple concussions. And these are slides of the brain which are called pathology or neuropathology to be specific. And it's a section of the brain which is stained with a color. There are different colors. And so this is what the normal brain looks like here on a gross level. This is what it looks like microscopically. And all those things that look like little triangles, those are nerve cells, and the lighter blue around it is the cytoplasm, whatever. And the white is the space, the parenchyma of the brain. And when you have repeated concussions, you get deposition of some abnormal protein called tau. And they can stain for that. So there's the tau. Looks None of that there. And so this is an NFL player here, and this is a boxer, the ultimate NFL player, because, and I'm against boxing, so is the American Academy of Neurology, because what is the purpose of a boxing match? Is to render your opponent unconscious, a knockout. But by definition, that is a concussion. What is a concussion? It's a form of brain damage. So boxing is the only sport where the purpose of the game is to give your opponent brain damage. I can't condone that. So that's pretty nasty. All right, so let's talk a little bit more about concussion. Millions of cases, happens in so many ways you can't even begin to imagine. Car accidents are the most, assaults, falls, I mean, you name it. We have a tendency to want to give things grades or qualify it. And so we have mild, we have moderate, we have severe. In the mild concussion, which this is the modern definition, by the way, the old definition was you had to hit your head, you had to be unconscious, you had to have, classic symptoms of headache and dizziness and perhaps vomiting and ringing in the ears and on and on and on. And it was learned after many years and lessons that you don't necessarily have to hit your head. It has more to do with how the brain moves inside the skull, back and forth, rock and roll. And some people just report that they're dazed. Some people report that they don't know what happened. But what's important is that they give a history of having some kind of a trauma. It could be a whiplash, by the way. That's an indirect way of getting a concussion. And that's the same thing as everybody knows the shaken baby syndrome, where the adult takes the little infant and they get mad and they get frustrated and they shake them, like, will you just shut up, because they can't take it anymore, right? And so what happens is that back and forth is the same thing as a whiplash. And the brain is going back and forth, and the babies get hemorrhages. So those are more severe concussions. Anyway, so the problem with the diagnosis of grade 1, which, by the way, is 90% of the cases, these cases go to the ER, go to the doctor, go wherever. They have a, quote, normal neurological exam, which is a very brief exam. It's not a detailed exam like I do. They do a regular MRI of the brain, it comes back normal. They may do a regular EEG, it comes back normal. And so basically the doctor can't find what's wrong through an objective test. And a lot of times the patients are labeled, as crocs, as phonies. The problem is that those tests are not sensitive enough. And you need to have functional tests which only include the SPECT scan, which I'll show you some examples now of concussions, or you can do another test called quantitative EEG, or computerized EEG. So let's look at some examples of the abnormal, and we're going to look at it in the same format that we did like before. So this is the single head, and after the single head I'll show you what's called the triple head. The triple-headed camera is the state-of-the-art, and you'll be able to see the difference. And so here's the first view. These are slices from the bottom up. And does everybody remember what those other ones looked like? How's your visual memory, guys? If you just look at this and... Is there somebody want to answer? Okay. If you look at this, just generally speaking, you see there's a lot of irregularity. And it looks like the cortical flow is interrupted. And when you look at it carefully, you can see here's red, here's green, here's red, here's yellow, and look where green is. Green is pretty low on the totem pole. That's probably about 20 or 30% flow. That's probably like a 70% reduction of flow. That's major. Anything more than a 20% decrease of flow is going to give you symptoms. So you can see this is all hodgepodge and doesn't look anything like what we saw on the other. So here's the other view. This is the slices from the front to the back, front, back. And remember what I said about this view here? I said that looks like supposed to look like a ring. Look at the progression of the colors. So the top is red, on the side it's yellow. Well, here's yellow. And look at the bottom, it's green. And that's actually probably looks like it's worse on the left than the right. And here you can see all the interruptions again. And here's the temporal lobes. This temporal lobe here it doesn't even fill out. It's supposed to be a circle. See, this is sort of like a circle. You can imagine a circle here. On the high resolution one, I'll show you the circle, or the wannabe circle. But you can imagine if that was yellow all around, that would be a circle. So this is missing over here, this is missing at bottom, and all over here. And towards the back of the brain, look at that. It looks pretty good, right? So I'm going to show you the next slide, which is easy to see the difference of perfusion from front to back. So again, here's the front on all of them, and here's the back. And there's like a pretty big difference between the yellow and the green and the interrupted. See, here's the bottom, right? And there's the right side, there's the left side. And if you follow this ribbon back, you know, it gets thicker, it gets more regular, and it gets the brighter colors. And that is the gradient that I was telling you before from front to back. Very easy to see. A difference of perfusion of probably 50 or 60%. Here's the 3D. Does everybody kind of remember what the other one looked like? It was all white. I'm going to give you another comparative slide on the next slide. But just to show you this, here's the view from the front. Sort of looks like a monkey. But when you look at this carefully and critically, what you see is that all these black areas are decreased blood flow in the frontal lobe. As the brain rotates to the right, you see it's all over the right side of the brain, but here's the back, and that's a lot better. It keeps rotating around and around and around. There you go, the back. You look at the back. Most of it's white. But if you look carefully, you got 3 or 4 spots here, and you got 1 there. And it clearly shows that it's worse on the left than the right. And clearly shows it's worse in the front than the back. And we see a pattern like that, a difference from left to right and front to back, that's highly characteristic of a trauma, concussion. So the next slide is the recapitulation to give you a better visual comparison. Okay, here's the normal. Here's the flow scale. There's the white. Everything is like Snow White and the 16 Dwarfs, because there's 16 pictures, right? And here is the one that I just showed you on the slide before. I think even a layperson can see the difference, right? Wouldn't you agree? So that's how we can diagnose it on a SPECT scan. And this person probably had a normal MRI and a, quote, normal EEG. This is a study that I did back in the 1990s, a little bit before the time I started seeing Bill as a patient. And I was working with a neuropsychologist at the time, and I was curious to see what was the correlation between all the different diagnostic tests that we did on the brain to see how they correlated. Because it was turning out that the SPECT scan was very good and the computerized EEG was very good, but the MRI was not very good. So we put it to scientific scrutiny. And what we found out that if we use neuropsych, I don't know if you, whoops, wrong button. This is neuropsych here. We use that as the comparison to if a person had, that's a psychological testing to see if the brain is functioning or not functioning. We use that to compare the SPECT scan, which is in turquoise, and the evoked potentials and different quantitative EEG here. And so when you look at this, here's the MRI here. If you bring it down to neuropsych here and see where they intersect, the MRI is abnormal in about 20%. That's pretty bad. And what that means is all this here, 80%, are normal. It doesn't help, especially if you have a lawyer and you're in a lawsuit and you have a negative test that hurts your case. The green is the SPECT scan, and that's about almost 80%. And the orange is one of the electrical tests, and that was like almost 90%. So we concluded that the functional tests were more sensitive and were better able to diagnose the condition when all the other tests were normal. So now we'll look at the modern. I'm going to take you up to modern times. Those are scans and stuff from yesteryear. But they were still better than all the other tests. And so now we're going to look at a difference of a resolution. What I showed you before was probably about 1 centimeter or 10 millimeters. And these slides, what I'm going to show you here is about 2 to 2.5. It's depending upon how they do the scan. And with digital analysis of these SPECT scans, we're able to actually create more views of the brain. We could do subtractions. We could do a lot of fancy things. And so let me show you what that looks like. So you see how crystal clear that is? And we only had about 10 or 12 sections to get through the brain, and I actually had this cut in half because I I like to stack them so you can get more information. Here's the bottom, and that's the back of the brain, the cerebellum, that always has the highest flow. And as you start to come up here, you see some irregularity here, and there's their flow scale. Actually, it's a more complex flow scale. The other one was 10 steps. This is 20, 23, or 24. And you see the same kind of an irregularity. You see it here, you see it there, you see it there, you see it there. That's the front. It's getting towards the top, and actually goes all the way to the top. So those are the axial views from the bottom up. And these are the coronal. And remember, I promised to show you the temporal lobes as a circle. Everybody can see that there because the right temporal lobe looks not too bad. Look at the left, though. Left temporal lobe is not good. It's very thin. It's very yellow. Over here, you can see it. I'm going to show you a blow-up of that later on. And look how subtle this is. Could you barely see that's missing something on the bottom there, on the left side? And that's the left frontal lobe, and that's the left temporal lobe, so that starts to get that asymmetry that I told you about before. Here's a blow-up of one of those views. And what we found was when we compare the findings on the SPECT scan, which again is blood flow, this is computerized EEG. We have the ability to do slices of the brain in EEG, and this showed an area on the right temporal lobe on the inside, and that's what this shows here. The images are reversed, but this is the right side. That's the outside, that's the inside, and that's the outside. So there was an agreement in the locality of that specific abnormality. Why is that important? Well, if you think that maybe one test could be wrong, the probability that two tests showing the exact same thing is remote. And also, if you have a lawyer, if it happens to be a legal case, when you have one test confirming the other independently, done at a different time, a different office, it's very helpful to prove your case, so to speak. So this was published, by the way. Is there a question? This actually is part of a case study that I published with Dr. Gluck. He's the other doctor that I work with in the office, in a very prestigious book. I'll show you at the end. So here's the slices from left to right. These are the side sections. And you can see there's a lot more. And again, if you just look at the front and the back, you see that difference. You can actually see these V-shaped areas on the top of the brain, which we can see better on some other views. Those V-shaped areas are very classical of a vascular injury. So now we go to 3D, and we have several different 3D now on these wonderful new pictures. And this is the 3D of what we call the raw data. This takes the data that we just looked at and just records it on the surface. And instead of having 16 views, we have it takes 2 pages. There's 4 times 8, there's 32, there's 64. So that's because it's so sensitive and it's so accurate. And so this is the left side, and you can see that there's a lot of blue here, there's a lot of blue there, and there's better flow there in the back. And that's the right side, and here's the left side. And it's hard to see it because of the size, but this is all. I'll show you that better in some blow-ups. And this is the back of the brain. See all the colors? Nice and colorful, right? There's your flow scale, right? Just to go back to compare. See how blue it looks in the front? That's the gradient, again, that I was telling you about. So here's a blow-up that I just promised to show you where you can really see it in detail. It's the left side of the brain, and the arrow is pointing to the tip of the frontal lobe, and it could be pointing there, but there's no limit to what you can show. And this shows that the injury was here, worse on the left and worse in the front in the temporal lobe, and you can see as it goes towards the back of the brain, it gets better. So that's the SPECT scan, and this is the quantitative EEG, the computerized EEG, which also has the capability of showing 3D. So look at the agreement in the left frontal lobe, and it's part of the publication we did. Now here's the same. This is a patient who was sitting in his apartment, and the ceiling fell on his head, and he got a head injury and he got a neck injury, and I don't know if the lawyer sent him to me or somebody did. And so here's another view of the brain, and as it tells you, this is posterior, And if you, this is the SPECT scan because you see the flow and the colors. If you look very carefully, it looks pretty good. But if you look more carefully, you see big blue here, big blue there, and more blue there. So this is actually a little bit worse than that. And guess what? Once again, it matched the quantitative EEG. That can't be a coincidence. It's statistically impossible. So this is what we call the coup contre coup. That's the famous French name to describe that if you get hit on one side of the head, the force carries to the other direction. So this guy was he was hit more on the left, so his frontal lobe got hit first, and then it bounced to the right, and it went at an angle. So if you were to draw a line between the left front and the right back, you can make an arrow, which would be a description of like how the forces went through his brain and shook and rattled his brain. I think I already said that. The lawyers love it, especially when you have pictures of objective testing. Here's the same patient, and these are cortical views again, but these are computerized. This is not the raw data. So this is models of the brain upon which the patient's perfusion is placed. And you can see this is the right side, this is the left side. This is the medial side, which is cut with part of the brain removed. This is the top, this is the bottom, this is the back, and that's the front. And you see a lot of green here. It's dark green. You see dark green. Dark green is the second color after blue. So that's really low here and there. And here's the bottom of the brain, and you can see it's blue. Very low. This blue here is an artifact. That doesn't count if anybody wants to know. So that's a lot of decreased blood flow everywhere. And some more of these fancy views. I blew them up a little bit. You can see it better. Green is not good. Blue is even worse. And you see that left temporal lobe? Remember I kept telling you it was worse on the left? All green. A little bit of green. A little bit of yellow. A tiny little bit of brown. And it actually goes a little bit towards the back, but not quite as bad. Yeah, this is, I don't want to spend a lot of time on this, but when you have computerized and digitized data, there's ways to analyze it further and to bring out certain abnormalities. So there are these special filters that are put on there, and these are just models of the brain. It's not the person's brain, but it's the person's perfusion. And you can see there's a big hole there. That's the bottom of the left frontal lobe in there, which he doesn't have it quite as bad on the right, but we knew that from all the other pictures. So this is really confirmation of what we saw before. And here's a blow up to make it easier for you. That's the bottom of the brain, the right and the left. I could have moved my arrow a little bit to the left, but okay, you see it, right? And here's the same view on a QEEG. And once again, confirmation. Confirmation. Cross-validation. And this is probably the last slide on this patient. And now I want to call your attention to another color scale here. This is not blood flow. So what this is a statistical comparison of the patient's flow against a normative data bank. What is a normative data bank? Well, they take people that supposedly have normal brains. They have strict criteria. No neurological conditions, never had a head trauma, never had a stroke, never did drugs, blah, 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 blah. No psychiatric illnesses, and they do their flow studies, and they record all the data, and they pool it. They pool it by the age group. There's about 3 different age groups, like kids and middle age and older, and then some of them do female, male. This one doesn't do it. So what happens is if the person in question, this patient who got hit on the head, if his blood flow is decreased, like we've seen in all these pictures, if it's significantly decreased, there's going to be a negative deviation from the norm. And if he has too much blood flow, there would be a positive. And we see that all the time on the quantitative EEG. And so what you see here on the base of the brain, that's the same view. All green, which is -2. See, that's a -2 deviations. Anything at 2 deviations or more is considered to be abnormal. And in this area, he has this dark blue, like he has over here, all on the left side, and that's between -3 and approaching -4 deviations. And he has it here on the front of his left temporal lobe and the tip of the frontal lobe. And he has a little bit on the right side too. So this actually confirms what we saw on all the other pictures, statistically. This is just another view. A little bit blown up. You see a little bit better here, a little bit better there. On the back, he didn't have too much. This is probably an artifact here. Here's the front. Blue, -3, -4, surrounded by green, which is -2. So clearly abnormal. I'm not going to spend the time on this. I don't know how I'm doing on time. Anyway, this is part of the publication. We did a correlation. 10 patients we did. And that data was published in this book, which is the editors that you see here, Robert Thatcher and Joel Lubar, who are both in Florida, lucky for us. They are both the international experts on quantitative EEG and neurofeedback, which is another form of treatment. So it was good enough to be accepted in their book. So, do we have any questions?
If you have any questions, we can walk around with a microphone. We have 5 minutes for questions. In the back. There we go.
Yes, doctor, I wanted to ask you why does the blood flow stop? What causes after an impact, after the concussion? Why does the blood flow stop? And also, how do you renew it? And is there a way to renew it?
Right. Very good question. We don't know the answer. Does the mic work? We don't know the answer %, but there's very, very good data that is due to a spasming of the arterial wall of the blood vessel. So instead of having a diameter of, let's say this, is a diameter of like that. And the best evidence that we have for that is if you give a certain drug, which is specific to dilate the arteries, and you can then demonstrate increased flow and return of neurological function, which is what I do all the time with these patients. It's indirect evidence, but it's pretty strong evidence that it's related to a spasming.
Question over here.
Somehow I believe I'm in the right church, but the wrong pew. According to you, the newspaper article, the headline is Reversing Diabetic Neuropathy, and you'll see reversal of diabetic neuropathy as well as the new techniques for amputation prevention. Also, you'll be speaking about...
You want me to answer your question?
Yes.
Okay, we have 2 presentations tonight. The neuropathy and the diabetic and the treatment for diabetic neuropathy is the next one. That's all.
I'm in the right church.
Yes.
Yes.
Doctor, thank you. For someone who's had TBI and it's affected the eyes and it's been a decade or more, is there the opportunity for treatment or recovery?
Do you know what the symptoms are relating to the eye?
Yeah. It's ptosis, extreme. I am the situation where I had cheeks rebuilt and the orbital floor rebuilt, and the ptosis and what looks like a sleepy eye, but it's not. It just never opened, except maybe twice in the last 10 years, fully.
Do you know the cause of the ptosis? Did you have a third nerve palsy?
Yes, it's 9, 5, and 3. Cranial nerves, 9, 5, and 3. They have a number to it, and also the atlas.
Yeah, well, that would be cranial nerve number 3.
And the atlas was, instead of tilted, it was unscrewed off the cervical one. The atlas.
What was unscrewed?
The atlas C1.
Oh, that has nothing to do with the eye.
Okay.
No, that's at the base of the brain. The answer to the question is that if the problem with the eye came from inside the brain, it is amenable to treatment, because the problem of ptosis can happen from anywhere from in the brain stem, along the way, the peripheral nerve, and then outside. So it depends where its localization is, which could be determined by...
Correct. That it can still be tracked. It can still be tracked, the origin of it. It can still be tracked, the origin of the source of the ptosis or the constriction can still be tracked?
Oh yeah, of course. Can the determination be made, you mean? Yes, of course. Any neurologist that's worth his salt should be able to make that diagnosis. But although I've seen a lot of sloppy neurology in South Florida, so...
We have another presentation, and after the event this evening, you'll be able to speak with Dr. Wan downstairs, so you'll have that opportunity. So,
I believe we have a video, right?
Yes, it's about to be keyed up.
Okay, so while we're getting the video ready, I'll give you just a little introduction. This is actually a patient of mine who had a horrific car accident about 10 years ago. She was basically crushed on the right side of the car, required the jaws of life to be extracted from the car. By the time they got her out, she was already in a coma. She had bleeding in the brain, she had multiple injuries, she had fractures. And they didn't think she was going to make it, but somehow she did. And she was in a coma for many, many months, and then she started to wake up, and it was a very slow process. And she came to see me, let's just say, in the beginning of January of this year, and the other doctor that I work with, because he does the other type of treatment called neurofeedback. And so this lady got the medication that the gentleman asked about, how to restore the blood flow, and also something else called hyperbaric oxygen. So let's look at what her neurological exam looked like. It's abbreviated here. We'll see it better. But let me just show you this first, okay? You see her head is tilted to the left. Her arm is all up in the air because it's spastic. Her knee, she can't bend her knees because there's what they call spasticity. It's increased tonus. All comes from the brain injury. So this is me examining her.
Scratch the bottom of your left foot like we did before. Don't pull back, all right? Okay, and she pulls back just a little bit, but you can see that the toes go down immediately. Okay,
Toes go down. Good, normal.
Okay, now concentrate on your right foot. We notice that the foot is a little bit red. This is a dependent rubor, which is related to the innervation of the skin. And she holds her right great toe in extension, which is also known as a tonic Babinski sign. But she does have some voluntary control over it. She is able to relax it. Jody, keep relaxing your right foot, your big toe. And I'm going to scratch the bottom like I did before. And please try not to pull back.
It went up.
No, relax your toe. Relax the toe. Let it go down. Let your big toe go down.
Toe has to be in a neutral position before I scratch the bottom.
Let it, okay, right like that. No, just let it stay down. Good, let it stay down. And I'm gonna, no, give me 2 seconds, all right? 2 seconds. Toe down, down. No, the other way, down. And now we see when I scratch the bottom of the foot, which is called Babinski, the plantar reflex rather, the toe immediately goes up, which is a positive Babinski sign. Okay, all right. Jody, you want to say something for the video audience? You want to try to say something for us? Huh? A little louder so we can hear. You want to come closer with the camera? Maybe we can catch it. So we say hello. Okay. How you doing?
How are you?
How are you?
Yeah.
Okay. All right.
Okay. Stop.
Okay, that'll do.
Yeah, one of the problems she had speaking is because there was damage on the left side of the brain which controls it, but she also had terribly slurred speech, which I think you could hear. She also had a very low volume, which is all under neurological basis. She also had terrific trouble swallowing, and I didn't show it because we started the video too late, but she doesn't feel when you put something in the back of her throat called the gag reflex. She doesn't feel it very well, which is a huge problem in the real world because patients like that try to eat, they swallow and it goes into the lung and they get a pneumonia. It's called aspiration pneumonia, so it's a huge clinical management problem. So here she is now, 5 or 6 weeks later, and I didn't mention on the first one, half of her visual field was gone on the left, which is why she was tilting her head to compensate to use her field on the right to see. So here she comes in a wheelchair and her head's pretty straight, right? And we could turn it on and you just see the examination. Maybe we won't show it all. I don't know how we're running for time. We have time? Okay, let it go.
Pause. Got it. Okay, I got it.
Right? So this is a follow-up examination of Jody, who was here between last December 2014 and through the end of February, and who had aggressive treatment for her severe post-concussion syndrome with some return of neurological function. She went back to Canada where she lives and continued to take the medication, nimodipine, and have physiotherapy but no other form of treatment. And they're here today for a follow-up examination approximately 6 months later, and to get a repeat SPECT scan. So now I'm going to do the neurological examination, and we'll be able to compare it to the previous one to see if there's any further neurological recovery. Okay, so Jody, first we're going to check your vision. All right, so just look straight ahead at me, and Mom, if you cover the right eye, and Jody, can you see my left eye, the one that's open? Can you see it? Yes? Okay. Is that a yes with her hand?
Yeah, yeah. No? Yes or no, Joe?
Do you see my eye? Okay.
A little stronger voice.
I'm going to hold up some fingers. So, no. You got to look at the eye. Only at my eye. I'm going to hold up the fingers, and you tell me how many fingers you see moving. Now look at my eye, and just say how many fingers are moving. How many is that?
3.
3 fingers?
I don't know, is that what you said? 3.
All right. Tell me if it's on the left side, the right side. No. Only look here. Tell me if it's the left side, the right side, or both sides. Okay? Keep looking at my eye. Which side is the finger moving?
Both.
Both sides? Both sides. Okay. Now we're going to do it one more time. Okay? Keep looking at my eye. Only at my eye. And tell me if it's don't cheat. Look at my eye. Tell me if it's the left side, the right side, or both. What's the answer? One finger?
Just one?
All right, point to the side where the finger is. That side? Okay, so that's the same. That's one quadrant is still out.
I'm going to put it on hold for just a second.
All right.
So we didn't see that on the pre-treatment because we didn't tape it properly, but on the first examination on the left side, she couldn't see anything on the top and the bottom. That was half of the vision that was gone, which is why her head was tilted. On this one, she could see it on the bottom half, but not the top. And that enabled her to keep her head straight, which is a big deal. And so that was part of the neurological recovery that she had 5 to 6 weeks, and then this one is 6 months later. So she's maintaining her improvement. Okay.
Okay, so now, I want you to look at my finger. Follow my finger with your eyes. Track my finger with your eyes. Don't move your head. Good. All the way. Look at your head. Look at my finger. Okay, all the way over. She goes all the way to the left, but you see the right, her left eye doesn't go all the way over, so she has some weakness there. Okay, now look it up. Look up, track it up. Track it down, so you can go down. You're not moving your head, just move your eyes. Now watch the finger come into you. Watch the finger, the right eye comes in, the left eye doesn't. So
It's hard to see, but the left eye still has some paralysis.
Okay, close your eyes tight, hard shut all the way. Squeeze tight all the way, hard. Squeeze, don't let me open your eyes. Come on, don't let me open them, hard. Keep them closed, squeeze tight, hard, shut. Come on. Jody, you're not closing your left eye. You gotta close both eyes, okay? Come on. I need like 2 seconds of full strength, okay? So do it again, hard. Yeah, she's not doing as much. Okay.
Come on.
All right. Wrinkle your forehead up. Okay, so clearly the left side is wrinkling. The right side has maybe a little bit of wrinkling here, but the right side has weakness. That's the side of the body that's affected the most. Okay, now show me your teeth, all your teeth, top teeth, as much as you can. Top teeth. Okay, it's actually pretty good. Right side goes up pretty good. The left side stays like that anyway. Okay, so it's much better. And stick out your tongue. All the way. Out. Come on. Out. More. There you go. It goes a tiny bit to the right, but before it looked like it was actually going out more straight.
Yeah.
All right. Okay. Put it in. Now, do you feel me touching your face, Jody? You feel that? You
Yeah.
said yes? Yes, okay. Does it feel the same or does it feel different?
One is the same, 2 is different. Okay. One is the same.
Same.
So it feels the same. Very good. Okay, so facial sensation is intact. Okay, now can you hold your arms up like this in front of you? All right, left arm goes out straight. How's the right arm doing?
Come on, Joe, move it. Yeah.
Does it move? Does it lift up? Let's see. Go ahead. Bring it up. Both arms up.
That's the paralyzed side.
Up, up, up. All right. Left arm out straight. Okay, fingers like this, palm facing the ceiling. Can you point the index finger like that? The one finger, you can, all right, you can pick that one. All right, index is good. Okay, now hold it. Okay, let me show you. Can you put the tip of the finger on the tip of your nose, eyes closed? Can you do that? As you close your eyes.
Coordination
Go
test.
ahead, close your eyes. Jody, close your eyes.
Still has a hard time with closing her eyes.
All right, now put the put the tip of the finger on the tip of your nose. All right, it's a little wobbly, but eventually
Yeah,
she
you see
gets
the
it.
tremor.
Okay. All right, now we notice that the right arm is held in a flexed position, and the fist is in a clenched or flexed position also, which is typical of when someone has this type of an injury or a stroke. And her arm is tight, and that's the spastic part that I was talking about before. And she has this fisting, which you see in people like that, and cerebral palsy children get that a lot. For the same reason, spasticity. This hand, she wants to hold it like that, but she has more control, she can open it. Can you hold the fingers up at all? Keep your fingers up. Ready? Straight up. Don't let me push you down, Jody. And I cannot push her down. So she has full strength there. But if I ask her to tap her fingers like this, she can do it, but very slow. Can we tap over here? Tap, tap, tap on the right hand.
Can't do it.
Can you make those fingers work at all? Jody?
Get your thumb up, Joe.
Index or thumb or any finger?
That's mom helping.
This is a bit looser than it was. Okay, now try. Move that finger up and down. There you go.
And she was able to do that last time too, I remember. But
Yeah.
that was about it.
But the arm is looser than it was.
Well, it's still very tight.
Yeah.
It's very, very tight. Okay. All right. Well, let's look at her reflexes, which normally they would be increased because
A sense of humor. She did that voluntarily.
Yeah, her reflex is very jumpy. It's a hyperreflexia.
Not too bad there.
And
Right side's going to be a lot more
this arm
active.
is also hyperreflexive. Sometimes it's not always hyperreflexive because it's so tight it can't move. Okay, we can turn off the camera for now. Got it?
Got it.
Okay, so now we'll do the reflex. Don't move your leg, okay, please, Jody? Now we'll do the reflexes in the legs, and we'll see. It's not going forward, and it's not going to the other side, so it's not that bad. See, this one is obviously very hyperactive. I'll get it, Jody, because I have to do your ankle jerk now. Let's see this ankle jerk. No, relax your foot. Relax your foot. And that's pretty normal. And so now I'm going to scratch the bottom of your feet, which is a very famous reflex. And the trick for you is not to pull back, okay? Even though it tickles, all right?
Yes.
I don't know what that meant.
Yes.
Okay, so Jody, I'm going to scratch the bottom of your foot to try not to pull back, all right? And did you see that on the camera? That the toes went down? I'll do it again. The toes clearly go
No
down,
question.
which is a normal response. This one is probably going to go up, which is not normal, but we'll see.
Notice that it's already flat.
There it is. The big toe goes up, the other toe goes up. That is the famous Babinski sign. And you see it stays up like that, which how it used to be. But when we did her treatment the last time, the toe kind of came down. So I could probably push it down and it will probably stay down. Although if you stimulate the foot anywhere in the area, it's liable to do that. Okay. Jody, can you feel me moving your big toe up and down? Yes? Okay, so I'm going to move it up, which will be number one finger, or I'm going to move it down, which will be 2 fingers, and you tell me which way it goes with your eyes closed, okay? Eyes closed, all right? Close your eyes. All right, ready? All right. Which way? Very good. All right. Which way? Is that one finger or two fingers?
Down.
Two fingers. She could do that. That's good. All right. Do you feel any vibration on your toe? Okay. Does that feel cold or warm? Cold is 1, warm is 2. Cold. It is cold. Okay. You feel the vibration on this toe also? Feel that? Does it feel the same on both toes? Okay, good. And if that's cold or warm? Cold is 1 finger, warm is 2 fingers, so it's cold. All right. Okay. I think we'll check the gag, huh? The right side.
Okay.
The right side and the left
We should
side.
prepare it this
This
time.
is such a big
Shall we just stand to the side?
deal.
And remember what happened the last time. You didn't see it, but you're going to see it now. The very first time, she didn't have much of a response.
Gag reflex checked in the hospital before, and
Nothing?
nothing.
Do you want me to pause or?
Yeah. Hang on.
Okay.
All right, so we'll do the
She's going to sit towards
we'll
us.
do the less affected side. All right, open your mouth, Jody. Oh, you can feel that. Okay. And that's this side. She felt it pretty good on both sides.
Yeah, yeah.
Turn it off. Let's see. All right, put your shoes on.
Okay.
Oh, that is
I think that's the end. You could, yeah. So, could people see a difference between the first examination and the second? You could see that? Yeah. And she had a repeat SPECT scan, and it showed increase of blood flow in a global manner and in certain parts of the right side of the brain, which was the worst side of the brain initially. Afterwards, the left side of the brain got to be the worst. Okay, if there's any more questions, we can do that and then go on to the next presentation. Yes, sir.
Real quick, what did you do between the first time and the second time? I mean, why is her blood improving? I mean, what are you giving her? You're giving her.
I'm giving her a specific drug called nimodipine, which is specific for the brain that increases blood flow. She also has hyperbaric oxygen chamber treatments, which does something similar but complementary. And she also had another treatment of biofeedback to retrain the brain electrically called neurofeedback. So it's very aggressive and very specific.
Would that the drug that you gave her, could that be used for normal people with slightly abnormal blood flow?
Sure. Sure. Yeah. If you can find a doctor who'll prescribe it. Yes.
Have you tried anything like sound waves, magnetic, radar, whatever, to increase the blood flow?
I have not personally, because this seems to work very, very well. They do use transcranial magnetic stimulation to treat depression. There is another type of treatment called neurofield, which is electromagnetic radiation of the brain. I have not used that, but my partner is going to start doing that soon, so we'll investigate that and get back to you. All right? Okay, oh, question in the back.
It's going to sound silly. What's the difference between a concussion and a contusion?
A concussion is a brief interruption of the ongoing brain activity. A contusion means where there's some physical damage to a part of the body that you could usually see. If there's a contusion in the brain, it's usually in the form of blood, and you can see that on the scan. The problem in the mild brain injuries that I described before as 90% of all the cases is that there's no gross bleeding, but most likely there's microscopic bleeding. No, that's why the scans are read as normal, and once again, it doesn't help. All right? Yes, sir.
Yes, sir. Yes, doctor. I recently saw a interview on TV with Dr. Gino Tutero talking about the pellet therapy, hormone therapy, sort of help along this along with some Hall of Fame football players who had traumatic brain injury.
Along with what, did you say?
Hall of Fame football player
Hall of Fame,
who
yeah.
had traumatic brain injury. And they have said with this treatment of the pellet therapy that they've found great improvement. And it's been endorsed by the Sports Association for Traumatic Brain Injury or something like that. Are you familiar with that?
I apologize. I'm having trouble understanding what you're saying.
No, I'm saying that
What does the treatment consist of?
it's a hormone therapy. It's a pellet therapy.
I believe there was an article in a Life Extension
And I
magazine
think
about
there was
that.
an article in Life Extension also.
Excuse me. Is my mic? The hormone aspect. Down, is that it? Or just turn that off and use that? Turn this off?
You're fine. Okay.
All right. There are certain concussions that affect the base of the brain between the hypothalamus and the pituitary. There's damage there. And that can result in a loss of all the hormones, depending upon exactly where the damage is. And those are important to diagnose through blood tests to check the hormone levels, and they should be replaced. But that has nothing to do with the rest of the brain, which is, under blood flow. And the SPECT scan is just not a popular test because MRI and PET scan just dominates the imaging, and the doctors are just not that familiar with it. That's the problem with the SPECT scan.
Is this the same test advocated by Dr. Amen?
Yes. Dr. Amen is the famous doctor, psychiatrist, and SPECT scanning famous. He uses it in a slightly different way. But it's good. Okay. Another question?
I just want to make a comment. I bought one of those vibrating plates that's supposed to exercise your entire body when you stand on it. And then after getting off of it, about the second time, I noticed that my vision was affected. It's almost like it gave micro concussions in the head because your entire body shakes, including the head inside your brain in your head. And I looked it up on the internet, and there was some research on that, but not very much. So maybe with your expertise, you could go and